Good morning, everyone. We'll continue part 3 of common pediatric illnesses. We'll continue the viral gastroenteritis we have started earlier. So we were talking about feeding and rehydration, and today we'll be talking about reinstitution of oral feedings. Some people, they might think if the child has diarrhea, you don't have to feed them, but in fact, in reconstitution of a regular diet should not adversely affect mild diarrhea in those patients. So therefore, continued feeding children use age-appropriate diet while avoiding simple sugars can increase osmotic load and worsen diarrhea in some situations. And continuation of oral feeding despite diarrhea episodes, it has some advantages or benefits. They will minimize the development of protein and energy deficits. They can facilitate the maintenance and repair of intestinal mucosa. They will promote recovery of a brush border membrane disaccharides or disaccharidases, and decreases the duration of illness and improve nutritional status. So therefore, in mild cases, it's okay to reconstitute or reinstitute oral feeding. We come now to drug therapy in case of viral gastroenteritis. Most episodes of viral gastroenteritis and diarrhea that results from this condition, they are normally self-limiting. So some people advocate the use of antibiotics. They are recommended, لكن بشرط في بعض الأحيان لازم يكون في عندنا bacterial component in that condition. If we have systemic bacteremia is suspected, the immune defenses are compromised, then we are afraid of having an opportunistic bacterial infection. A persistent enteric infection is sensitive to antibiotics and depends on the isolated microorganism, of course. If you have Shigella or Campylobacter, Vibrio cholera, Clostridium difficile, E. coli, strains are isolated, of course, we need to give antibiotic in these circumstances. In general, anti-diarrheal preparations, they are not recommended. When you go to the pharmacy, you will see a lot of anti-diarrheal drugs, and they give it, in large quantities to patients. But generally, if you want to stick to the correct guidelines, they are not recommended for infants and children because 3 reasons. The first one, they have little effect on acute diarrhea. So why should you stop them? Or why should you give them? Number 2, associated with side effects. Number 3, direct attention from the use of oral hydration therapy. So the patient think that this is the main medication to treat diarrhea and they ignore rehydration, which we really need. So the best treatment in this condition is really rehydration therapy. Other people, they might think of these drugs. Here I have 5 therapeutic interventions or treatments. We will start with the first one, loperamide, Vacontil. Loperamide, it alters or works through the changes in the GI tract or GI motility. It should be avoided, especially in children with high fever, toxemia, or blood mucoid stools. May worsen the clinical course of the bacterial infection. Therefore, it might be misleading if the patient is using loperamide, and it might direct the attention from the main or the key cornerstone of a treatment, rehydration, versus this drug to stop diarrhea. Number 2, bismuth subsalicylates, anti-secretory and antimicrobial effect. They will inhibit secretion and they have some antimicrobial effects. They have not been shown to provide the clinical benefits. Therefore, bismuth subsalicylates are not recommended. Number 3, adsorbents. These adsorbents like cow pictate or cowline pectin or atabugate or gite adsorb. They are supposed to work by absorbing bacterial toxins and water and lessen the symptoms of diarrhea by producing more formed stools. There is no evidence of their effectiveness, therefore they are not recommended. Number 4, zinc supplementation. Zinc has been recommended by the WHO, especially in developing countries, for the treatment and the prevention of diarrheal diseases in children. Mechanism of action, best method of administration, and efficacy in different populations are not well understood. Therefore, it might be used. There is no special recommendation about it. The biggest group that some recent studies they talk about the probiotics. These probiotics are live microbial products, basically lactobacillus, which is the most common, and bifidobacterium, Saccharomyces or Streptococcus. They can improve the balance in the normal flora, trying to restore the normal flora, and they work by different mechanisms. One of the mechanisms that there is competition between this bacteria and the harmful bacteria, so they can kick them out of the GI tract. Some of the studies, they claim that they might produce certain toxins that will affect the other bacteria, but still, they could be used, and you can buy them as capsules sometimes. The next most common disease in children is gastroesophageal reflux disease. Sometimes we call it GERD, gastroesophageal reflux disease, or GERD, or GER sometimes they call it, gastroesophageal reflux. It's a common disease. It happens with 50 to 60% in infants. They might experience recurrent vomiting and regurgitation. Regurgitation ارتجاع المعوي أو المريء اللي بتصير عند الأطفال during the first months of life. It happens a lot, and most of these reflexes, they are believed to be caused by one of the following or more of the following causes. Maybe due to a transient relaxation of the lower esophageal sphincter. That LES sphincter is kind of loose. It will open upward. Instead, it's a unidirectional sphincter, but it can open both ways because of that relaxation. Can get food and gastric acid upward. Body positioning. So think about body positioning when you have the child slumped over in a car seat or lying supine. مدد الطفل يكون تمديد انه بعد الرضاع، فسهل جدا انه يصير في عنده نوع من gastroesophageal reflux or regurgitation. Consumption of a liquid feeding that exceeds the volume capacity of the stomach. الطفل keeps crying, the mom or the caregivers keep feeding them milk over and over again. So this will lead to kind of extension of the stomach beyond the capacity of the sphincter, so regurgitation might happen. In premature infants, sometimes a decrease in peristaltic movement or activity. This normal peristalsis of the GI tract, it's kind of under normal, below normal. Undiagnosed underlying conditions that predispose them to reflux. Example, neurologic disorders, hiatal hernia, hypertrophic pyloric stenosis, and cow's milk protein allergy. Sometimes certain infants, if they have allergy to milk, they also might have allergy out of that gout. Yes, okay. In case of reflux in infants, 80% are benign, which means the outcome are not too bad, and they resolve by 18 months of age. Just leave them without treatment, they will be improving. But certain others, you should not untreated. We will talk about them in a few minutes. Reflux in older children resolves in a time frame similar to that of adults. If untreated, if GERD is left untreated, it may result in esophageal strictures, تخثرات أو closures or constriction. May also lead to GI hemorrhage or chronic respiratory disease from the aspiration of GI contents. That's a big concern, in fact. If you have food or milk or a fluid coming out of the GI tract and get aspirated into the lungs, that's a really big problem, might lead to choking and suffocation. And studies evaluating the relationship between GERD and asthma or Helicobacter pylori have shown mixed results. Some studies, they have shown there is relationship or correlation between them. Some results or some studies, they have shown no correlation. Now, what is the clinical representation? What are the signs and symptoms if the child, how do we know if the child has GERD? In infants, the vomiting and regurgitation of GER or GERD occurs frequently, and other symptoms often are non-specific. They can help in diagnosis, but they are not specific for GERD per se. Examples is failure to thrive, FTT, recurrent pneumonia because of that aspiration, we talked about it, pulmonary aspiration happens, apnea, difficulty of breathing, dysphagia, difficulty of swallowing food, reactive airway disease. As you see, most of these are related to lungs. Because of that, regurgitation happens, the risk of aspiration into the lungs is high. Apparent life-threatening events, a late or ALT, and hematemesis is a blood coming out with vomit, and anemia because of the malabsorption. This because of the food is not going normally from the stomach into the intestine. It's going to go up again. It's going to be kind of a vomit. Then we might have anemia in this condition. Now, how do we treat gastroesophageal reflux disease? Uncomplicated cases, they normally resolve spontaneously in infants. We don't have to worry about them if they are uncomplicated. Focus on providing symptom relief and maintaining normal growth, because we are worried about malabsorption and getting benefit out of these nutrients. Then the big concern is to keep normal growth going. What are the goals of therapy? When we treat GERD, what are our goals of therapy? The first one is to lower the symptoms or lessen the symptoms. We need to control these symptoms. Number two, if we could heal esophagitis. Number three, we need to prevent any complications, especially if we have pathologic GERD. Sometimes we might have to do surgery. So they will refer them to a physician to do surgery for them. The first part of the treatment is non-pharmacologic, where we talk about the positional and dietary measures. Positional is, think about the position of the infant. Sometimes if you feed and put in supine position, that might be a bigger problem. It will aggravate the thing. And the feeding measures, try to avoid overfeeding or by incorporating feeding techniques. Sometimes infants might have milk allergy, especially if they have lactose intolerance. Therefore, there is certain formula, it's a soybean or soya-based protein formula or hypoallergenic formula should be tried. Therefore, modifying the infant's also position is, sometimes they believe it works, sometimes it doesn't. So modifying the body position or to modify infant feedings with milk thickeners. You put, because of the milk is very fluid, some people, they might add a milk thickener like rice cereal, for example, put some cereal in it. in order to prevent frequent throw up or vomiting, but there has not proven to be really effective. But these are certain measures you could take. So more frequent, smaller feedings are also another option. Instead of giving a large meal, just divide it into smaller ones and give it more frequently so you don't have a baby to suffer from malnutrition. Mild cases of GERD often can be treated successfully by dietary measures alone, as well as by propping infants in an upright position during and 1 hour after feedings. So you keep the body of that infant in kind of upright position during feeding, and also for 1 hour to make sure that the body absorbs that food. Some people they tend, or some mothers tend to put the face or the body of the child face down, a prone position during sleep. This is really very dangerous. It might improve GERD symptoms, but the bigger problem, it might cause sudden infant death syndrome. They can't move, they are very little, they don't have strong muscles, they can't roll over. So the risk of SIDS or SIDS is also there. And sometimes we hear some reports about children, they die while they are asleep. So because of their breath, of course, they cannot breathe, then they will just suffocate and die. Older children and adolescents, they should follow the recommended dietary guidelines as adults, especially when we talk about dietary restrictions, to avoid caffeine, chocolate, and spicy food. So these are dietary guidelines normally we follow in adults. So all the older children also, they should follow the same guidelines and procedures. The GERD drug treatment, the efficacy of pharmacologic therapy in altering the course of uncomplicated has not been proven yet. So when esophagitis is present, because of that esophagitis inflammation and the burning sensation, we need to give acid suppression in this condition. It's always recommended to give acid suppression in esophagitis to aid in the healing process. It's very painful, and these agents alone do not rectify the cause of GERD. So if you give antacid, do you think antacid is the solution to treat the causes of GERD? They are not. They're just kind of symptomatic relief to help healing the process after esophagitis. So you suppress acid production by giving antacids. This table is showing the oral drugs that are normally used in children to treat gastroesophageal reflux. The different class categories. The first one is acid suppressing agents, antacids. Again, you know this, they have aluminum or magnesium hydroxide. The mode of action, they neutralize acid production. This is the oral dosage. And before and after feeding, you need to give them. The class number 2 is the proton pump inhibitors, or the PPIs. We have omeprazole, esomeprazole, lansoprazole, pantoprazole. These, they work by decreasing acid secretion via inhibition of the gastric hydrogen potassium adenosine triphosphate. With tally, they will reduce the production of acids in this way in the gastrointestinal tract. Another class, this as you see is the antacids, or sometimes we use them in ulcer also in adults. The H2 receptor antagonist, or H2 blockers, the cimetidine, famotidine, ranitidine, nizatidine. These, they work by blocking H2 receptors to reduce acid secretion. Class number 4 is the prokinetic agents like bethanicol, metoclopramide, erythromycin. as you see, they are different. For example, metoclopramide antiemetic, erythromycin antibiotic. So each one has a different mechanism here. For example, bethanicol, a cholinergic agent, stimulates peristalsis to increase that peristaltic movement of the GI tract, to increase the lower esophageal sphincter pressure, increase gastric emptying, increase colonic motility, gastric emptying, etc. Metoclopramide, it's a dopamine antagonist. By antagonizing dopamine, it works on the vomiting center in the brain. And erythromycin, motilin, again stimulates smooth muscle contraction. We have the last group is the surface active agent sucralfate. It forms a paste and adheres to damaged esophageal mucosa. So that's the mechanism of action. It's kind of a protective layer against that. Will adhere to it and cover it. So this way will reduce the pain that's caused by GERD. So okay, there is some questions I think you guys might have. So لؤي عليان إذا في مجال تترك لنا 5 دقائق. لؤي بحكي لك يا لؤي، في عنا تقريبا إحنا يعني مش 5 دقائق، نصف ساعة. So زهراء بتسأل, are these available in dosage forms other than tablets for children to be able to take? Yes, most of them they are available as tablet or liquid. For example, ranitidine موجود على شكل liquid. انتي اسيدز موجوده على شكل ليكويد وموجوده على شكل تابلت كمان. ميتوكلوبراميد موجود على شكل ايفن سابوزيتوري، موجود على شكل دروبس، موجود على شكل ليكويد سيرب. يس يا لؤي، ايش المشكله؟ اذا بتحب تحكي بتطلع انا ميوت ويو كان توك. خليني بس احكي انا. اوكي لؤي. لؤي دكتور، احنا بس بدنا تتعاون معنا عشان تقريبا كلنا خريجين، وصراحة دكتور بطلنا ضامنين النجاح.